So we are live now.
Yeah.
A very good evening to everyone. I am Arpita from the IGCP group. The topic that we are going to cover today in our webinar is sexual dysfunction, post-prostatectomy, reconstructive approaches, and patient counseling. And yes, to address this topic, we have with us Dr. C. Sharat Kumar sir. It's an honor for me to welcome sir to our platform and to introduce to everyone. Sir is MBBS, MS from UK, DRCOG UK, PhD, super specialist in sexology and infertility. He is practicing at Dr. Sharath Men's Clinic, he's director there, and also Mediway Fertility Research Hospital. So with this introduction, sir, now I would request you to please start with the topic for today. Over to you, sir.
Yeah, thank you very much, Arpita. Thanks for your nice introduction. Good evening, all the doctors. Today's topic is very, very interesting. It is the management of sexual dysfunction after prostatectomy. That is the topic. I'm going to cover the subject under these headings. And the prostate surgery, it is quite successful nowadays because of advent of recent techniques where minimal invasive surgeries have come. Many people with benign prostatic hyperplasia, prostatic cancer, any problem with prostate causing urinary tract infections, LUTS, all of them, they undergo this prostatectomy. And earlier, hardly anybody used to notice about the sexual dysfunction, erectile dysfunction after the after the prostatectomy. Now people are aware about this sexual dysfunction, so they do come for counseling what to do after the prostatectomy. So regardless of surgical technique, prostatectomy results in disruption of normal anatomy, nerve supply to the penis, which governs the functional aspect of the erection. A variety of different treatment options are available for men who develop ED after prostatectomy. So any type of surgery on the prostate by any method, it will cause some certain amount of damage to the normal anatomy and nerve supply to the penis, which will result in the erectile dysfunction. So we have to go under the following management methods: counseling, give them vacuum erection devices, then start with, if that doesn't work, start with the oral PDE5 inhibitors, and if it doesn't work, then go for intracorporeal injections, and all these, if they fail, then go for the penile prosthesis. So you know the definition of erectile dysfunction. I don't want to go into the details of erectile dysfunction. Straight away I'm jumping onto the treatment aspect. Treatment aspect starts with the lifestyle management. So lifestyle changes, psychosexual therapy, medicines, injections, vacuum pump devices, and other treatments are the things which are available. So regarding the lifestyle changes, if the person is a smoker, ask him to quit the smoking. If he is an alcoholic, ask him to reduce the consumption of alcohol. If there is drug abuse, immediately stop it. If he is obese, ask him to reduce the weight, and ask him to go for good sleep routine, manage the sleep apnea, ask him to go for regular exercise and eat healthy diet. So these are all quite applicable for all the management of all the types of sexual dysfunctions, including erectile dysfunction, either after prostatectomy or for any person in general. And nutritional supplements are very important source of energy for the penis. L-arginine, L-citrulline, propanol, L-carnitine, flavonoids, zinc, vitamin D, folic acid, L-methylfolate, DHEA, ginkgo biloba, ginseng, Panax, ginseng. These are all some of the nutritional supplements which help in the management of erectile dysfunction. See that some nutritional supplements are given to post-prostatectomy men. So there are herbal products which they claim that it works excellently on erectile dysfunction, but they are not proved by double-blind control studies. However, people do use Hygrophila spinosa, Gokshura, Ginkgo biloba, ginseng, ashwagandha, shatavari, safed masli, tulsi beach. So these are said to prepared for this and accept the things as it is and where it is and start the treatment wherever it is possible. So for the men, stress related partner should be because of the prostate surgery itself, like any other sexual dysfunction. That's very, very important aspect. And the second one is counseling is done to the partner also, so that the partner starts cuddling the person and encourage him to for rehabilitation of the post prostatectomy sexual dysfunction, and ask him to encourage him to take the treatment so that he quickly recovers from the sexual dysfunction. So couple counseling is very, very important in all these cases. Same drugs we use for any other person with inhibitors, phentolamine, apomorphine, yohimbine, intracavernous injections, that is prostaglandin, E1, aprostadil, papaverine, and intraurethral suppositories, that is alprostadil. Every one of you know the PDE5 inhibitors, importance of PDE5 inhibitors, sildenafil, which started as Viagra. We can start with 25 mg, then increase to 50 mg, and then go up to 100 mg. Tablet has to be taken 1 hour before the intercourse. Tadalafil low dose 5 mg can be given daily, or it can be given on 10 mg and 20 mg also. It has to be given at least 30 minutes to 1 hour before the intercourse. Vardenafil, that it comes in the tablets of 5 mg, 10 mg, 20 mg. It should be given 1 hour and power Modula, EDSave, Mildfill, EFill, TEDAC, Cilias, Cialis, Teraflow, Xidalis, etc. There are second generation medications. If the PDE5 inhibitors, that is primary tablets, that is if sildenafil and tadalafil fail, then go for avanafil or lodanafil, meridonafil, and urinafil. Melanocortin activators, these are drugs that appear to act through central nervous system, that is through the brain. They have been shown in animal models, but they have not yet to come to the market. There are certain contraindications for PDE5 inhibitors. They are taking nitrates to treat chest pain, they should avoid. If they have got severe heart disease, they should avoid. Having low blood pressure, they should avoid. Side effects are well known: headache, facial flushing, backache, giddiness, then nasal congestion, dyspepsia, visual changes, blue halos, optic neuropathy, and priapism, of course, very rare. There are other oral medicines available, apomorphine and yohimbine. They do work to some extent. If medications, that is oral medicines, fail, then it is advisable to go for intracavernous injections. They can be taken by the patient himself. Alprostadil is the popular one, that is Caverject or Vidinafil, which it has to be given in the dose of 5 to 40 microgram per injection. It is independent of nervous system. Manual dexterity, adequate vision training is required. Contraindications are bleeding disorders, sickle cell anemia, multiple myeloma, leukemia. Side effects are penoscrotal pain, hematoma, fibrosis at the site of injection. Priapism is a deadly complication. The other injections available are papaverine, phentolamine, aviptadil, vasointestinal peptide can also be used. All these injections can be used solo or in combination, called as bimix or trimix. So penile injections, popular is alprostadil 5 to 10 microgram, papaverine 30 to 60 milligram, phentolamine 0.5 to 2 milligram, aviptadil 25 micrograms. They can be given as bimix and trimix. You can see in the picture the method of giving the injection, you should choose a place about 1 to 2 inches below the glans penis, that is corona of the glans. And the best angle is either at 2 o'clock or 10 o'clock. That will avoid the corpus spongiosum and the urethra. Self-injections, the person can be trained to inject himself. It is a more invasive. Injection site soreness can occur, priapism can occur, penile pain can occur, possible scarring or infection can occur at the site of injection. These are all some of the side effects of this one. All prostadil creams are available, but they don't act that much vigorously as the injections are concerned. All prostadil urethral suppositories are inserted into the urethra. Side effects can include pain, minor bleeding. All prostadil can also be applied as a topical cream. It is not available easily. This is how intraurethral alprostadil is injected into the urethra through an applicator. So there are alternative managements. Penile rings are available. It has to, also called as cock rings. It can be put in the base of the penis so that it will sorry, it will stop the venous outflow from the penis and cause the penile erection. And person can do the intercourse and remove the ring after the intercourse is over. Vacuum pumps, the other alternative treatments are PRP injection, that is platelet-rich plasma injection, low-energy shockwave therapy, acupuncture therapy, vacuum pump devices, vibrator therapy are also available. Vacuum pump devices are excellent. They come with a constricting ring at the base of the penis. The side effects are cyanosis, edema. The erection is cold erection. It is not warm. Pivots at the base of below ring. Maximum time you can apply the vacuum pump and the vasoconstrictor device is 30 minutes. The most vacuum pump constrictor devices consists of a shrink ring cylinder pump, by either powered or manual or by battery power. It employs negative pressure to dilate the cavernous venous sinus, increase the perfusion of cavernous artery and venous blood flow, and ultimately achieve the goal of producing penile erection. An external constricting ring is placed at the base of the penis to prevent the blood flow during the intercourse in order to maintain an erection. It's used to promote the recovery of the penile function and maintain the penis strength. So this is how the vacuum constrictive device works. When the negative pressure is applied, the penis gets erected. In addition, device can only increase the oxygenation of the corpus cavernosa without the use of shrink ring. This method can bypass the limitation of oral drugs. Compared to penile rehabilitation therapy, vacuum constrictor devices therapy has the advantage of being non-invasive and fewer side effects. Other comes the low energy shockwave therapy. It has recently been developed for treating the ED, and it has been shown that it does work. This results show that induces cellular microtrauma, which in turn stimulates the release of angiogenic factors and the subsequent neovascularization of the treated tissue. This is how the low energy shockwave therapy is given, and it is also called as low intensity extracorporeal shock wave therapy, that is ESWT. It is a non-invasive, low intensity sound waves are liberated through the equipment, and it is given to the soft tissues, that is to the erectile tissues, restoring natural erectile function by clearing plaque out of the blood vessels and encouraging the growth of new blood vessels. Shockwave treatment offers a cure, that is, it reverses the problems that causes dysfunction in the first place, the most desired win-to-win outcome coveted by the men with ED. There are, of course, electrical stimulations. They are not used nowadays because of side effects. Penile vibrators, they do work to a certain extent by giving vibrations that stimulates the nerve endings, but the erection is not guaranteed. Genital vibration is potential treatment for sexual dysfunction related to a wide variety of sexual health concerns in both men and women, a valuable tool for healthcare providers in the treatment of sexual functions. If all these fail, the final answer is, of course, the surgical intervention, that is implant, that is prosthesis. Modern penile prosthesis originated in 1970s, and there are several types of prosthetic surgeries. That is, it comes with the semi-rigid malleable silicone rods, two-piece inflatable hydraulic pumps, three-piece inflatable hydraulic pumps. So these are the types of prosthetic surgery available. The best one is, of course, malleable prostate. Very simple. Silicone rubbers are introduced into the corpus cavernosa. The side effects are negligible, and the surgery is quite simple, and it is very economical also, and easy to do the surgery also, and minimal risk of mechanical failure. So disadvantages of the silicone rods are major disadvantages. The semi-rigid device is in the penis always, and the penis is always rigid, erect. That is, it can be only flexed. That is, it can be only with the help of hinges. It can be folded, but the penis will always look big and large. The device may interfere with urination, difficult to conceal because the bulge is always seen, and have a higher likelihood of device erosion. Malleable processes is most commonly utilized in resource poor settings for the patient who want device with minimal complexity. The best one is, of course, the next one, two-piece inflatable processes. These inflatable processes are introduced into the corpus cavernosa. A pump with fluid filled, that is saline filled, will be inserted into the scrotum, and the pump, it pumps the saline into these cylinders, and these are compromised between the use of placement of and potential expansion. Ultimate is, of course, this is how the two-piece pump is put. The two pieces, two cylinders, and one pump. The ultimate is three-piece inflatable processes where there is an additional reservoir which will be put behind the pubic symphysis. This is the gold standard for treatment of medically refractory ED after prostatectomy. These devices consist of paired penile cylinders, scrotal pump, and a reservoir for saline that is placed in the suprapubic space or posterior to the rectus fascia. So this is how three-piece pump is inserted. Three-piece processes provide excellent rigidity when erect and a more natural appearance when flaccid. When fully erect, they are as rigid as the two-piece devices. In the flaccid state, they surpass flaccidity of two-piece processes. Results are quite good. 90% of the patients with these prosthetic surgeries have got satisfaction. High satisfaction rate is there. Men willing to undergo implantation of penile prosthesis are self-selecting group and may not be representative of the general male population. Complications, of course, of implant surgery, just like any other surgery, this also may have complications, surgical complications, anesthetic complications, local infections, and other things. And if the person is diabetic, the chances of the complications are more. The other treatment is PRP, that is platelet-rich plasma injection. This PRP is injected into the penis, and it has got excellent results for persons who have got ED, and of course, ED with post-prostatectomy patients also. PRP speeds up the neurovascularization and therefore increase the blood supply and nutrients influx necessary for cell regeneration in the damaged tissue. That's how the PRP works. And it is less invasive, and the platelet-rich plasma can be directly injected into the corpus cavernosa. So friends, prostate surgery is quite common. Prostate enlargement is quite common, especially in men after 60 years. Patient who undergo surgical removal of prostate, whether by radical prostatectomy or cystoprostatectomy, will often experience impairment of erection in the early post-operative period due to disruption of the blood and nerve supply. Surgical technique, nerve sparing status, patient age, comorbid conditions, and pre-treatment potency status all have an effect on post-surgical erectile dysfunction. Vacuum constricted devices, oral PDE5 inhibitors, intracorporeal injections, and penile processes are used for the treatment of the erectile dysfunction after the prostatectomy as a part of rehabilitation. Erectile dysfunction rehabilitation has been shown to provide more rapid return of the erectile function. It is better to start the rehabilitation quite early so that even before total damage to the tissue occurs, the patient will recover from the erectile dysfunction. With careful patient counseling, proper treatment selection, high patient satisfaction, and improved ED for erectile function can be achieved. We advise that patients use vacuum erection device daily in the early post-operative period in combination with either on-demand PDE5 inhibitors daily, those are on-demand. As the erectile function improves, the dependency on one or the other can be withdrawn. For patients who do not respond to a VCD or PDE5 inhibitors, consideration should be given to the intraurethral alprostadil or intracorporeal injections, or finally penile processes. So friends, thank you very much for your kind attention. And if there are any questions, I'll be very happy to answer you. Over to Arpita for the further deliberations.
Thank you, sir. Thank you so much. I must say that was a very insightful presentation.
Thank you.
And almost it has covered all the points that were necessary. Still, let me see if there are any queries.
Yeah, sure. I'll be very happy to answer.
Yes, sir. Sir, the first question is, how do you determine the ideal timing for initiating penile rehabilitation therapy post-prostatectomy to optimize sexual function recovery?
Yeah, as soon as possible. Once the prostate surgical wound heals, once the person feels normal, maybe after 15 days, after he recovers from the initial hiccups of all the surgical things like anesthesia and other things, once he feels comfortable, we can start. Usually 15 days after the surgery, it is better to start. First, start with vacuum constrictor device. It is simple, non-invasive. Then add the PDE5 inhibitors, maybe after 3 weeks or 4 weeks. Earlier is the better. But the only thing is the person, that is the client, should feel comfortable and he should have come out of the surgical trauma.
Right, sir. The next question is, among the reconstructive approaches such as nerve grafting or penile prosthesis implantation, which do you find yields the most consistent patient satisfaction, and what factors influence your choice?
3-piece inflatable prosthesis. This is the one which is the best one, because the penis will be flaccid when it is not inflated, and it becomes rigid when it is inflated. And the patient satisfaction is 90%. And the only thing is cost factor. It costs more heavy for the burden, anywhere from 4 lakhs to 15 lakhs rupees. The surgical cost occurs, depends upon the surgeon and the place where he operates and the comfort for the patient, whether he is going for a 5-star hospital or a 3-star hospital or a small nursing home. Depends upon this one. The cost of this one is about 1.5 to 2 lakhs, and surgery is about 2 lakhs, means it can start with 4 lakhs and onwards, upwards. This is the best one. Patient satisfaction is ideal, and it is placed like this. The reservoir is placed behind the pubic symphysis. The two cylinders are placed, one on each side of the corpus cavernosa, and the pump, that is the bulb, will be placed into one of the scrotum towards one of the testes, and it is quite easy to operate. When the pump is pressed, erection occurs. Same pump can be used for deflation also.
Right, sir. So your choice is the 3-piece pump.
Yeah.
Yep. So next question is, what counseling strategies have proven most effective in setting realistic expectation for patients and their partners regarding sexual function recovery?
Yeah, good counseling if the partner accepts the person, that is the client, and if she starts encouraging him to use these vacuum pump devices and gives the tablets regularly, reminds him to take a daily dose, and give a good massage, pelvic massage, and give a good vibration using a vibrator, give vibrations all around the pelvis. And if she is good in oral stimulation, give a good oral blow job and hand job, so that the nerves get stimulated and rehabilitation occurs quickly. So, and also she should encourage him to see that all these equipments are used, because most of the times they hesitate to use all these things. And frankly, if they open up and if the couple are quite good and understanding, rehabilitation becomes very, very easy. So psychosexual counseling for the partners is very, very important, crucial.
Sir, one last query. Are there any novel pharmacological or regenerative techniques on the horizon that show promise in improving outcomes for post-prostatectomy sexual dysfunction?
Yeah, the best one is platelet-rich plasma injection that gives excellent results, because it will give neovascularization and clears up if there are any clots and if there are any plaques. And the best one is, of course, the platelet-rich plasma. I'll show you. So that gives very, very encouraging results. Yeah, this one. So PRP penile injections involve taking the blood, centrifuges, separate the platelet-rich plasma from the blood and inject into the penis to promote tissue growth and give better sexual performance. It male enhancement also occurs, and it is non-invasive, and it's a patented medical procedure, well accepted worldwide, designed to improve man's sexual performance, increase the performance, and also speeds up neovascularization and increase the blood supply, nutrients influx necessary for the cell regeneration in the damaged tissue. So plasma and platelets, they play a vital role in rehabilitation of the penis after post-prostatectomy.
Right, sir. These were all the queries for today. So on
Thank you.
behalf of the entire IGCP team, sir, I
Yeah.
extend our heartfelt thanks to you for your
Thank
insightful
you.
and
Thank you so much.
thought-provoking
Thank you for
presentation.
giving me an opportunity to address
Thank you,
you.
sir. The
Sorry, from
clarity.
past 2 months I could not come online because of my bad throat. I had little
Yes, yes, you were not doing well.
laryngitis, so my voice was very bad. So I didn't wanted to expose my good friends with my bad voice. So I avoided giving the online this one. From here onwards, I'll be more regular. I'll be very happy to meet my esteemed professional colleagues through the IJCP. As I repeat every time, IJCP is doing a yeoman wonderful service, connecting the super specialists with all the general practitioners all over the India, and of course all over the world also. Thank you, the whole team. Thank you, Arpita, and thank you, Ankana, for continuously calling me and fixing up the date in spite of my not answering her. She never misunderstood me. She went on pursuing me to give the lecture. Good night, Shubharatri.
Thank you. Thank you so much, sir. Thank you for your time. Thank you so much. Thank you, everyone. We are closing.